Hey, good morning, everybody. Welcome. This is Health Talk, and of course, special presentation of Providence Health and Services, Western Montana. We do this every Monday from 8:30 until 9. We always have a different guest, and I want to say thank you to Dr. Mark Weber for taking time out of a very busy day to come be with us. How are you, sir?
I'm fine, Peter. Thanks for having me.
Good to see you. Now, let's talk a little bit. I even wrote this out. I want to make sure I get it right. What is a physiatrist, which is what you are?
I get that question all the time.
Or physiatrist.
You can say it both ways.
Okay.
I'm a doctor of physical medicine and rehab, and that's a pretty wide area, but I guess the best way to tell people or to define my field is to give them an idea where it came from. And in the 1940s, World War II was finishing up. We had a lot of disabled GIs returning from the war, and many of them had severe disabilities, and our medical system really wasn't designed to treat or to help them re-enter the community and society. So my field really came into being at that time. And then, as medical technology has improved, we have a lot of people surviving major traumatic and life-changing events like a stroke or a traumatic brain injury or an amputation. And my field is really designed to help those people restore their function and to get back into the community.
Now, from what I understand, what you do is primarily based with, is it a body-mind combination? Because oftentimes when people are in that situation, they have major problems trying to accept what has happened to them in the first place, and then not only that, but dealing with the physical implications. So, do you work together with other aspects of the hospital to try to help make that happen?
For sure. These are major traumatic events for a lot of people, and there's an adjustment to that psychologically and emotionally. And we have a great staff. We have a psychologist on staff who works with our patients and helps them through that process.
I remember when I put my hand in a snowblower. It was a long time ago, but I remember I was one-handed for a long time, and it took me quite a long time to realize that there are certain things that I have a hard time doing with one hand, and so I needed some help with rehab, things like that, especially when my fingers came out of the cast and they didn't work.
Sure.
So I had to basically reteach them how to operate, right?
Definitely. And imagine a person with a stroke who loses the function of an entire side of their body.
Right.
They really have to learn how to do basic things, dressing, bathing, eating, for that matter, not to mention walking or climbing stairs. So that can be a real challenge.
Now, tell me about the acute rehabilitation unit. What is that? Obviously, for acute means cases that are farther along than most.
So we have a special part of the hospital where our rehab patients stay, and they receive a very intense therapy service.
This is inpatient, right?
Correct.
Okay.
Correct. So you're staying in the hospital, and there's an entire team on this unit that I sort of lead, and then I have really great therapists working with me, physical therapists, occupational therapists, speech therapists. We mentioned the rehab psychologist. Then we've got an entire team of rehab nurses, a social worker, really a comprehensive team that is organized and meets on a daily basis about each one of the patients and helps to design and specifically tailor the rehabilitation plan so that, at the end of 2 weeks or 3 weeks, however long the patient is there, they're ready to go home, and we've taken care of the issues.
It sounds to me like your job is being a combination physician and in some cases like a cheerleader, right?
Correct.
So tell me what those first few steps are like for someone who may have undergone a severe disability of some sort with an accident or a stroke or whatever, and they begin to make those first few minutes of progress.
Sure. They're meeting a group of people that are going to help them, and they have to build trust first, and usually that's established pretty quickly. The team is very professional. They get to work quickly. Patients start to feel comfortable. They start to see those little tiny improvements, and then we start to build upon that, and they add to each other, and eventually a patient, they can't believe how far they've come, and that's really a good thing to see. It makes my job really worth it.
Now, do you find that I don't want to say it's easier or harder. I guess is there more of a challenge when it's an older person, someone who is kind of set in their ways, they have routines, as opposed to a younger person like a child or a teenager who may be able to bounce back quicker? Is there some difference between the two?
Sure. I think just from a physiologic perspective, a younger person really recovers faster than an older person, but it's not tremendous. It really, I've seen young people take longer and old people get well quick. So it has a lot to do with the injury and how severe it is.
So is there one particular kind of injury or disability that you work with more often than any other? Because you just mentioned at the opening of the program that basically your form of therapy began pretty much in World War II, and of course Iraq and Afghanistan has produced a lot of folks who were very severely medically damaged.
Sure. Our unit, our rehab unit, is a comprehensive unit, meaning that we treat all patients. And, we certainly see a lot of strokes. We have a lot of patients with traumatic brain injury. We have some patients with spinal cord injuries. And then there are orthopedic injuries. You fracture your hip, you're having trouble walking. That's another large area that requires rehabilitation.
Now, I have noticed that we live in horse country.
Yes.
And there are a lot of people that are injured, whether because they forgot to wear a helmet or a horse, it bucks them off and they land awkwardly and things happen. So has that happened quite a bit, or do you treat those folks as well?
Sure. We see a lot of horse injuries, thrown from a horse, things like that. So I do encourage people out there to wear their helmet. It is important.
Yeah, and be careful.
For sure.
Yeah, when I was younger, I had a horse and I bounced.
Yeah.
I don't bounce anymore.
Right,
so.
right.
Anyway, we're going to come right back. Dr. Mark Weber is joining us this morning. By the way, he's a physiatrist. If you have a question or a comment, give us a call. Lines are open, 721-1290. We'd love to hear from you. And I also want to talk about a certification that called CARF. Can we do that when we come back?
Sure.
All right, we'll be right back. Again, our number is 721-1290. Stay with us. And we're back on Health Talk, sponsored by Providence Health and Services, Western Montana. Dr. Mark Weber joining us here in studio. Before the break, Mark, I asked you about CARF. That's a certification. What does it mean?
It stands for CARF, and it's an international certification agency for rehab units. And basically, every 3 years, they come into our unit. They spend 2 complete days with us, with every member of our team, administration, other people in the hospital. They interview them. They look through our records, our policies with a fine-tooth comb. And at the end of that period, they decide whether we meet their certification requirements. And thankfully, and not surprisingly, our unit has passed that certification now 3 times. We also this year had really a tremendous achievement in that we achieved subspecialty certification, which is above and beyond the basic level of certification in 3 specific areas: stroke, traumatic brain injury, and amputation care. So.
Wow. Now, you had just mentioned during the break that there's a rather startling statistic that has come forward that people might be surprised to hear.
Sure. This weekend I heard on a news program that based upon the last census results, that 1 in 5 people in the United States is disabled physically in some way.
Wow. So how do you define disabled then?
Well, basically think of it as not being able to do something you could do previously because of something physically that has happened to you.
So it doesn't necessarily have to be something profound, but just could be something simple.
It could be quite minor, and that can affect people, though, in their daily lives. If you're not able to do something you enjoyed tremendously, then that can be a pretty profound thing.
Sure. So are certain functions more difficult than others to restore, or do people sometimes have to accept, I just can't do all the things I used to be able to do?
Frequently when someone is left with a permanent disability and the function doesn't return, we always hope for return of function through rehab, and that happens a lot. But sometimes people are left with permanent disability, meaning we can't make it better. Mm-hmm. What we do then is we try to train the patient, the person, how to do something more efficiently, easily, use adaptive equipment, and in many ways you can restore the function without actually restoring the ability, and that's a tremendous benefit to most people.
That sounds to me like it requires a great deal of training.
It does. It requires a lot of people that understand the process and can use the equipment and the technology that we have effectively.
So when someone looks into your, and obviously people study and look up your unit, what you folks do, when they see that CARF certification, what does that tell them?
It's like a seal of approval. It tells them that unit is functioning at the highest levels and meeting the highest standards of rehabilitation medicine.
Now, it says here you got your specialty certification not only in stroke, but also in traumatic brain injury and amputees.
Correct.
So you've worked extensively in all these fields.
Yeah, I've been very lucky. I have significant training with those patient populations, and it really is what makes my job exciting, is that I see a good mix of different issues and patients, and it keeps me on my toes, so to speak.
So now we talked a little bit about inpatient, a much more intensive type of rehab. What about outpatient? What kind of things do you offer there?
Sure. I have an outpatient service also where I follow many of the patients that I initially started treating on the inpatient unit. They've gone back to the community, and we keep in touch. We see each other regularly and make sure that they're continuing to improve, and if they encounter difficulties, I address those there. And then, there's a unique patient population, the amputee population, that they have really specific and particular needs that have to be addressed, and I have a specific clinic for them where I see them with a prosthetist who is a professional who makes the prosthetic device. Because
during the break you were singing praises of your prosthetist, right?
Sure. We're very lucky to have an exceptional prosthetist working with us, and I've worked with quite a few in my career, and he really is remarkable.
Now, these are not basically, I hate to use this term, I don't want to trivialize it in any way, but these are not off-the-shelf type things. These are specially made for each person?
They are custom made, and they literally fit like a second skin in many ways. The interface between the prosthesis and the person has to really be custom, and it's made identical to them.
So how does that differ with a child who needs a prosthetic leg or arm or hand or whatever? Obviously, the child's going to grow.
Sure. As a child grows, we have to change the prosthesis frequently. And it really has to meet their needs for the specific phase of their life. If you take a toddler, they're going to have different needs than a 12-year-old amputee.
Okay. So what is it that gets you charged up when you get up in the morning and your feet hit the floor and you say, okay, I'm going to work this morning, yahoo. So why is that?
The part I love about my job the most is the team. I really enjoy working with the team of people, and every day I get to go in and participate in the care of patients with this incredible team, and we're all kind of directed towards the same goal. And that's a nice feeling when you have really professional people working alongside and making a difference for patients.
We're going to take a little break, come right back. 721-1290 is our number. Dr. Mark Weber is joining us this morning. And if you have a question or a comment, maybe someone in your family has undergone therapy here at St. Patrick Hospital, Providence Health and Services, give us a call, 721-1290. We'd love to hear from you, and we'll be right back. This is Talk Back, and it's Health Talk. Sponsored by Providence Health and Services, Western Montana. And, of course, Dr. Weber's here with us this morning, and I want to talk a little bit about Parkinson's disease. And can you tell us, first of all, what is that disease and what does it do? Well,
Parkinson's is a chronic disease that affects a certain area of the brain. And the area of the brain that it affects really controls our movements and how
we fine motor skills, things like that?
Fine motor, even larger things like walking. And so Parkinson's patients you'll frequently see have movement issues. They may have a tremor. They may also have balance problems, and that's the most common problem, is that they fall. It's easy for them to fall. And in the rehab field, we really work with Parkinson's patients trying to reduce that risk of fall, because that can lead to further injury. If you fall and you fracture your hip or your femur, then you have additional disability added on to your Parkinson's disease.
Now, Parkinson's, can it be controlled through medication, or is it a case-by-case basis?
The symptoms of Parkinson's disease can be improved with medication, for sure. And neurologists treat Parkinson's disease with a variety of medications, and they really have done a nice job at controlling the symptoms, but frequently patients still have issues. They still have things that are difficult, and they frequently work with a physiatrist and a rehab team to improve those issues.
All right. So when the Parkinson's begins, is there a way of putting it into remission, or is it going to keep getting worse, or is that, again, case by case?
It typically is a progressive type of disease. We do not have a cure for it. We do have treatment options and medications. Some patients choose to go for what we call deep brain stimulation, which is an additional way of treating Parkinson's disease.
Okay.
So
Now, what about arthritis?
Sure. Arthritis is a major medical problem in our country, and we have people living longer, doing more, and frequently the joints wear out before the person wears out, so to speak. And so, yeah, arthritis is a major problem.
And now, forgive me my ignorance here. What's the difference between arthritis and rheumatoid arthritis?
Rheumatoid arthritis is a very specific form of arthritis that is inflammatory in nature, meaning that there's actually a systemic inflammatory response that destroys the joints. Whereas osteoarthritis is more the wear and tear arthritis that most people have. It's just caused by, continual use of a joint, and the joint starts to wear down. People say bone on bone. You hear that a lot. And
right.
That's the osteoarthritis.
Now, there are a lot of people out there that have had, complete knee, complete hip, shoulder, whatever joint it might be, a replacement surgery.
Sure.
And with those, you don't just jump up and start doing all your normal stuff again, right?
You do not. Right.
So, can you just take those three, say shoulder, hip, and knee, and the different rehab that you go through with them?
A lot of those patients I do not see. The insurance companies have really determined that these patients either go home or they go to a less intense level of rehab. Okay. Some of them do come in and see me, especially people who have had bilateral joint replacements, meaning if you have both of your knees replaced at the same time, you can imagine the disability is profound.
Yeah.
So those patients really do require that inpatient rehab expertise. Most patients who have a single joint, let's say a knee, a hip, a shoulder, they do pretty well, and usually by 2 or 3 days after the surgery, they're doing enough function that they can return home. That's not to say that they don't need additional rehab. Right. These patients frequently have home therapy or outpatient therapy.
So when someone, again, I have family members who've had knee surgery, and one was elderly. At what point do you realize, you know what, I'm not just complaining here. There's something wrong. So something isn't working quite right. So would they call someone like you to say, first, let's try some rehab to see if we can make it work?
Frequently before a joint is replaced, we try to exhaust all of the conservative measures that you try to do before surgery. So frequently strengthening, some form of rehab with a physical therapist, addressing the muscles around the joint, trying to make those as strong as possible. And frequently that can extend the life of the joint considerably. And sometimes people can avoid surgery altogether in that case. It certainly never hurts to be stronger when you head into surgery or joint replacement also. So that's another one of the benefits.
Well, I'm sure that's true of any surgical procedure. The better shape the person is in overall, the better they're going to come out of it, right?
Definitely.
Yeah. All right. So what we kind of touched on a little bit, about a minute and a half left in the program. So our aging population, are they sending more and more people into the inpatient or outpatient programs?
Definitely. The longer patients live, the more likely they are to experience some form of disability. And patients are really seeking this rehab out, trying to make sure that they're getting the best care and they're improving as much as they can. So I often tell patients to be aware of their options, to be aware that there are really great facilities like St. Pat's Rehab Unit in the community, and to request them.
Okay, we have a minute left. So, Dr. Weber, if you wouldn't mind telling us, how do we contact you, and what are the prerequisites before we need your services? Well,
certainly patients are welcome to call if they have a question or are wondering about referral to the rehab unit, and the best way to reach us is 327-3260, and that gets you right to the rehab unit.
Great. Again, thank you so much for being with us. We appreciate it.
My pleasure.
And you're welcome back here anytime.
Thank you, sir.
And now, just find out if you're a real doctor. What do you say when I say it hurts when I do this?
Don't do it.
There you go. All right. You have now passed medical school. Sorry, but I just had to try that.
No.
All right. See, he was on to me. Anyway, so thank you for being with us,
You're
Doctor.
welcome.
We appreciate it. That's going to do it for Health Talk for today. And we'll be back next week with another edition brought to you by Providence Health and Services, Western Montana. We've got an hour of open phones on Talkback on the way, starting at 9 o'clock. Stay with us.